Hey, welcome everyone to this webinar this evening. It forms part of our webinar series that our Level 7 diploma students deliver. And I'm really excited to introduce B tonight because she'll be talking about a very important topic, hEDS in an athletic population. And I think it's really important because there's not much awareness about it and knowledge about it in an athletic population. So I'm really looking forward to this evening to learn more from B. And I know she's done an amazing job. Lots of research. She had to do a lot of work drawing from adjacent research and trying to put it all together and provide some really interesting insights and strategies for us this evening. Now, before I pass on to B, I just wanted to just quickly talk through our Level 7 diploma because we have a new intake starting in a few days. So it is our flagship sports nutrition program within our course portfolio, and it is delivered fully online. And it is equivalent in education standard to a postgraduate diploma at university level. It consists of two long base modules. So the first one is your integrative body systems, and that's where we look at the different body systems, so detoxification, gastrointestinal, musculoskeletal, and so on, from an integrative point of view in an athletic context. And then our second module is more your applied performance nutrition, but we always bring in an integrative slant to it. And then students go on to choosing 4 specialty modules. And we have quite a variety of specialty modules now on offer. So just to give you some examples, relative energy deficiency in sport, hypertrophy for sport and exercise, ergogenic aids, gastrointestinal health, which we're actually starting on Wednesday. And these can be done as CPD as well. So if anyone's looking for just some short CPD, these are some good options. And there's a variety of other ones if anyone's interested. It's on our website and you can have a look. And then students, after completing their specialty modules, they then go on to doing a 6-month practical mentoring and case studies module. So they get to experience different practitioners and professionals and see how they work, basically. And then they complete the diploma with a research project. Now, the diploma is open to individuals with a university degree or level 6 qualification. But we also accept applications from professionals that have a relevant qualification, professional qualification, plus some industry experience. So just to give you some examples, we've had health coaches before with us, as well as personal trainers and strength and conditioning specialists. So as I said, the next cohort is starting on the 28th of May, which is Thursday. So if anyone is interested in finding out more, just feel free to send us an email and we can provide more information. Right, now on to you, B.
Hello, everyone. Thank you for joining today. I have a very large subject, which I hope we can get done in an hour. I am known to be a fast talker, so let's hope this works to my advantage. So let's show the people who we are, Simone. So if you go to the next slide. So my name is B, and I'm currently doing the postgraduate diploma that Simone outlined here at CISN. I've been doing it since 2025. My background academically is in osteopathic studies with a focus on manual therapy, which I did at the Scandinavian School of Osteopathy in 2022. I am also a level C sports trainer and sort of verified by the German National Sports Association all the way back in 2014. And I've recently completed a nutrition mentorship with an incredibly amazing sports dietitian based in Portland, Oregon, called Marissa Michael, who specializes in the climbing population as well as REDS. My athletic history, I come from roller derby as my primary competitive sport. I'm now very much retired, but I used to play on the German Berlin League team, and I was a coach there as well as coaching the German national team. So I'm really proud about that one. I currently have retired from anything too strenuous, but maybe competing in regional Swedish dog agility might be considered strenuous. You can see me here on the left with my dog, Australian Shepherd Bowie, trying to do Swedish regional agility dog comps. In my spare time, I'm a hobby boulderer and sports climber and hiker, which is very easy when you live on the west coast of Sweden, because that's where I am in Gothenburg, which is a host and array of amazing climbing and hiking. I work as a Pilates instructor across multiple venues in Gothenburg, and I'm a part-time baker. The reason I'm doing this particular subject, which is close to my heart, because I myself am an athlete living with a hypermobile hEDS, Hypermobile Ehlers-Danlos Syndrome. It's a mouthful. I got my diagnosis in 2024, but we'll get into it. So let's start. Let's find out what this thing is. So, as it's a very meaty, lengthy subject, I've split it into two parts. So the first part, for a lot of people who don't know or are unfamiliar with this condition, we're going to go into what hEDS is, or hEDS also it's known as. And then in the second part, we're going to go and dig deep into more specific nutritional interventions. So I want to make a note, which Simone mentioned, is a note on evidence. As this condition generally is very under-researched, trying to find a sport-specific population with this condition is next to impossible. So I had to draw on a lot of adjacent literature, from connective tissue biology to autonomic medicine and gastrointestinal physiology, as well as applying some clinical reasoning, because most of the evidence out there, if you look at this taxonomy of evidence here that I have on the slide, is in the lower tier of evidence, so observational studies and expert opinion. So we have to really advocate for more hEDS research, but specifically in sports populations. So let's move on to the next slide. So what is hEDS? Let's start at the beginning. As Julie Andrews in The Sound of Music says, it's a very nice place to start. And the name Ehlers-Danlos comes from two dermatologists back in the turn of the century. One Danish dermatologist called Edvard Lauritz Ehlers and Henri Alexandre Danlos, a French, yes, terrible French accent, but in the turn of the century, they published observations on specific patients with very bendy bodies and very soft, velvety skin that was also hyperextensible. And that was the first sort of notation in medical literature of this condition, and lends its name to the condition, which is Ehlers-Danlos Syndrome, so EDS. So it's not just a joint problem, it is a multi-system connective tissue disorder. And hEDS is driven by the intersection of three systems, primarily a genetic predisposition, which affects the connective tissue architecture, a hormonal fluctuation, which can amplify symptom flare-ups, and also a neuroimmune component, which adds to dysregulation of the nervous system, as well as immune system. So the exciting news, though, is in this vast landscape, which is lacking literature and knowledge, in 2026, in December this year, a collaboration with the American Journal of Medical Genetics and the Ehlers-Danlos Society is coming up with a huge genetic publication where they've done the genome sequencing of 1,000 participants across 86 countries to find out the genetic component which could have a causative effect on this condition. So let's move on to the next slide. So May is hEDS Awareness Month, so welcome. I'm making you aware to this condition. Here's some fun facts, and maybe not so fun facts. It takes an average of 22 years to get a diagnosis of this condition. That's pretty hefty. And as you can see, I've put a rabbit hole depiction of Alice in Wonderland, because trying to study this condition opens a can of worms, and you just fall into this hole of big is small, up is down, And it becomes more confusing and maddening and very complicated. And you can imagine how it is for those who are advocating for themselves and have either are asking for a diagnosis or have the diagnosis. We have a 4-to-1 ratio of female to male who are diagnosed, but this is probably very underdiagnosed, as the male representation or presentation of this condition is very unknown, which is very rare in research, that finally women's presentations take precedence in this. But I think that there's a highly underrepresented male population that isn't accounted for here. And sadly, 90% of people with this condition report being dismissed at least once by their doctor. Now, I put a little zebra here because it's become the symbol of advocacy for EDS, because those with Ehlers-Danlos syndrome and hypermobility in general, most medical students, when they're being taught differential diagnoses, are told, and this is a quote, "When you hear hoofbeats, think horses, not zebras." So think of like the most obvious diagnosis, the most prevalent diagnosis. But those working in EDS research and advocacy say sometimes when you hear hoofbeats, it really is a zebra. So it's become the animal and the representation for people with diffuse symptoms and who have unfortunately had to experience medical gaslighting to get a diagnosis. So let's move on. EDS has 13 subtypes, and I will not go into all 13 because that will mean we would be here for 4 hours at least. We are focusing on hypermobile EDS, which is the most common subtype, and ironically, the only subtype without a causative genetic variance. But hopefully in December, this will change when we get that update from the hEDS study, and we'll find out if there are new diagnostic criteria to help expedite the diagnosis of hypermobile EDS. It's also really important that without this genetic component that we turn to diagnostic tools, inclusion criteria, so finding out all of these diffuse overlapping symptoms and signs and presentations of the disease, or the condition rather, and also maybe a history of people in your family who either present with the same symptomology or have a diagnosis, and also chronic pain and injury history. So let's move on. So when people think about hEDS, they think about just bendy bodies and joint instability, but it's so much more than just that. It is a musculoskeletal condition. It is an autonomic and vascular condition, gastrointestinal and neurological. So it's a spectrum, a clinical spectrum that it's important to distinguish between. It's also a case of having asymptomatic hypermobility and symptomatic. Many individuals with asymptomatic hEDS never develop pain, instability, or functional impairment. And they may even find this an advantage in activities such as dance, gymnastics, or yoga. However, people with symptomatic hEDS, by contrast, it involves recurrent challenges such as musculoskeletal challenges, especially with things like recurrent subluxations of the joint or dislocations, poor proprioception or understanding where your body is in space, and slow recovery and injury. A big one is also POTS, postural orthostatic tachycardia syndrome. Try saying that when you've had a few shots after a long day of studying, which is an issue with the drastic variance in heart rate whenever you stand up. So this is also due to the connective tissue in your vessels being compromised, because that too is connective tissue, not just your ligaments and your tendons. Then we have gastrointestinal issues. So a very interesting correlation is people with hEDS have a high recurrence of celiac disease, but also a lot of IBS and GERD-related symptoms. So gastroesophageal reflux disorder, constipation, diarrhea, and definitely a disrupted microbiome due to absorption issues due to compromised tissue in the gut lining. We also have neurological and cognitive issues. There's actually a high correlation between neurodivergence and the hEDS population, but we'll return to this a little bit later in the slides. So let's move on to the next slide. So we have a diagnostic score for scoring for or tool for hypermobility, and it's called the Baton score, which is a 9-point screening tool. And as you can see in the diagrams, it's a joint complex assessment. So you can see that there's different parts of bilateral positions and joints in the body that need to be assessed for how hypermobile they are and unstable. You're probably going to have a minimum of 6 out of 9 to be assessed for hEDS. If you are a child, or it's probably a little bit more. If you are over 50, it's about 4 out of 9. So the Baton score, in my opinion, is an insufficient and very basic assessment tool. You want to pair this with your sign and symptom expression, as well as family and injury history. It's a really useful starting point, but it can present with limitations because a lot of people with hEDS are, funnily enough, not hypermobile. And we'll have a look at that, why that is later on. And later on is now. So hypermobility is a misnomer. Many hEDS athletes are not globally flexible. The condition creates joint instability, and the body responds by building compensatory muscle tension and fascial stiffness. And you're bracing in your nervous system, so your guarding patterns come up. So an athlete might be tight and restricted and not hypermobile as a compensatory factor to stabilize unstable joints. So therefore, you'll actually see elevated muscle tone, or hypertonia is a common feature, actually, an under-recognized feature, where the muscles work overtime to stabilize lax joints. And it's often in parts like the cervical instability, upper back, so tight traps. You're looking at hip impingements or vascular compression in the inguinal canal area. You're looking at jaw tightness and potential dislocation of the jaw. So your masseter might be exceptionally tight and you might be grinding your teeth at night. So those are the most common ones. But also proprioception. What is proprioception? It is a sense of your body in space and your movement in space. And because with the lack of stability and the disconnect with the connective tissue and the nervous system, we sometimes don't actually know where we are in space. And that can lead to a lot of clumsiness. Clumsiness is a big feature in people with hypermobile Ehlers-Danlos syndrome. So for athletes, this means compensatory patterns and inefficient motor programming. So not just loose joints. And I like to use the following analogy when it comes to this condition. To be an athlete with hEDS is like using battle ropes on a stand-up paddle board. That's how unstable. And so you are exerting more energy and more muscle contraction to be able to execute a movement while maintaining stability at the same time. Let's move on. So I talk about connective tissue. Connective tissue, what is connective tissue? It is everything necessarily in your body, and it is informed by collagen. And in the case of hypermobile ADS, the problem is not the amount of collagen, but how this collagen is organized. So it's the collagen structure, specifically the fibril disorganization. Here on the left-hand side in the slide, you can see an image of a normative person without hEDS and their collagen structure, which is nice, tight, compact, and strong. And then on the right-hand side, you can see somebody with hEDS, which is disorganized, splintered, and lax. So this oftentimes is incorrectly assumed that hEDS patients are deficient in collagen or have low circulating collagen, but this is not actually the case. And any amount of collagen supplementation you use will actually be, in my opinion, a waste of money. As collagen is not the issue here, it's the DNA expression of collagen architecture, not amount. So here the more likely or helpful nutritional intervention will be targeted and structural support via amino acids, which we will approach in the second part of this webinar. So let's move on. Connective tissue. So we talk about ligaments and tendons, and we talk about the joints, but it's more. It's your fascia. It is connective tissue is the lining of your blood vessels. It is your skin. It is the lining of your gut and your gastrointestinal system. It is the epithelial cells in your brain and the surface of your neurons. And it's also your pelvic floor and bladder. So there's a lot going on here when it comes. So when we talk about connective tissue disorder, as I said, we're talking about a multi-systemic functional challenge for people with hEDS. So if we move on to the next slide. Often there are many comorbidities, an endless list of comorbidities when it comes to hEDS, but there are three, which I call the clinical trifecta. And it is something called mast cell activation syndrome. So often people with hEDS will present with one of these three, or sadly, sometimes all three, but there's always an overlap between them. So one is mast cell activation syndrome. One is what I mentioned before, POTS. Let's call it POTS because who wants to say postural orthostatic tachycardia a million times? And dysautonomia, which is an impairment or dysfunction of the autonomic nervous system. So your rest and digest, your heart rate, all of those more automated nervous system functions. So when it comes to MCAS, so mast cell activation, we're looking at hyperactive immune cells called mast cells that are concentrated in the barrier tissue, so your skin, your gut, your airways, and they're perineural, so they're above nerves, and they're also above your blood vessels. So when you have flare-ups, it's not always food mediated necessarily. It can be mediated and triggered through exercise, through heat, through stress, through environmental triggers like cleaning products or fragrances. And why is this especially relevant for athletes? Because we have to also mitigate the environments in which hEDS athletes train, as well as the foods that they eat. So are they training outdoors? Are they training indoors? What scents or cleaning products are being used in the gyms and studios where they train? So why this is important? A mast cell is an immune cell that when it degranulates, which means when it bursts open in a reaction to an environmental trigger, it dumps a host of inflammatory mediators, so chemical alarm signals, if you want. And one of them is called histamine. And this is the main protagonist that triggers a range of outbreaks from hives to headaches to migraines, sleep issues, acid reflux, brain fog. The list goes on, appetite issues, pain sensitivity. So why is this? Well, we'll come to that a little bit later. This one is a complicated one that really crosses over into a host of contradictory advice when it comes to nutrition and training. Then we have POTS, which is the raising of your heart rate on standing. And when the blood vessels fail to constrict and appropriately, so it directly you'll get a lot of dizziness or this feeling of about to faint when you stand up. And then your heartbeat has to be, well, that's also debatable, but it'll affect as an athlete your perceived training exertion and capacity, as well as your fluid intake, which again, we'll discuss in the nutritional interventions part when we come to clinical interventions for athletes here. Now, when we talk about dysautonomia, we're talking about impaired thermoregulation, exercise intolerance, fatigue, linking psychological stress with physical load, and then in turn, that will trigger MCAS flare-ups. So it's maddening, I told you. Let's move on to the next slide. So when we think about athletes with this condition, we want to think about where hypermobility might be seen as an advantage. And they're often in gymnastics, dance, climbing, swimming, martial arts, pole vaulting, all of those types of sports where being flexible or hypermobile is seen as an advantage. Now, the thing here is that athletes are disproportionately represented in this particular these sports, because it's both underdiagnosed, because their flexibility is treated as a talent and not a symptom. And there may be athletes with a diagnosis, but we don't actually know, because revealing this information as an elite athlete might be seen as a competitive disadvantage. So getting a diagnosis might actually be seen as working against them within an elite context. So they are simply not diagnosed, as their symptoms can fall under other conditions like overexercising syndrome, low energy availability, or REDS, and with recurrent persistent injury being dismissed as just part and parcel of their sport. So it's either underdiagnosed or not revealed. So truly knowing who in this particular sports population has hEDS is going to be very difficult to discern within a research perspective. So we move on to the next slide. So pain sensitivity is a big one for this population. And we're looking at central sensitization, which is prevalent active, so chronic pain here, where the central nervous system amplifies pain signals long after the injury or trauma has subsided. And in an hEDS person, the nervous system runs on high alert constantly, even at rest, as their interoception, which is their sense of their body's internal state, so things like hunger, satiety signals, thirst, or even fatigue signals, it's disrupted. So it's very unreliable in athletes and may not register that they are under fueling until it's very severe, too late, or results in injury, unfortunately. Now, psychological or physical stress, even stress induced by training adaptations or competition, also activates the hypothalamic pituitary adrenal axis, which is our main stress response axis in our body. So what happens is this will end up leading to the release of cortico-releasing hormone, which then releases mast cell degranulation, and then boom, pain is amplified. In the case of athletes, the training load, competition anxiety, poor sleep, life stress, all feeds into the same inflammatory stress loop. So we move on to the next slide. So within this population, not just athletic population, neurodivergence and mental health is a big issue. So we see with hEDS population that there's elevated rates of ADHD and autism, and it's very well documented. So there's proposed shared mechanisms to do with connective tissue, autonomic dysregulation, and cognition, but it's a mechanistic and not a behavioral issue. So there is an underlying connective tissue issue. Then we're also looking within this spectrum of neurodivergence sensory sensitivity. So texture of food, smell of food, temperature of food, sounds that not related to food, maybe munching. I personally hate it when people smack when they're eating. They're also commonly affected. So we end up like correlating food intolerance with probably food avoidance. And also because the food avoidance, if you're relating food being triggering mast cell or MCAS, then you're also running the risk of certain eating disorders, which we'll touch on a little bit later. But also just the act of and the mental health burden of trying to get a diagnosis will have compound anxiety, depression, and PTSD symptoms, which is very elevated in the hEDS population. So it's really important when you're working with an athlete who has hEDS, who's probably been to a million clinicians and has fought for a diagnosis, or is still fighting for a diagnosis, and is doing a lot of their own self-advocacy and research, that you do not use nocibic language, as in pain-related language, or pathologize the person and reduce them to their symptoms and signs. This is a human who is struggling, and they probably need your empathy and support more than your expertise. I know that's a controversial statement here, but let's move on to the next slide. We made it, people. We made it to the nutritional interventions. So let's have a look at what we're dealing with. We're starting off with GI function and fueling. So a big problem here with the hEDS population is things called dysmotility, gastroesophageal reflex disorder, and your compromised microbiome. I really wish I had picked a subject where I could pronounce all of these conditions a little bit easier. So what happens is we have a lot of times gastroparesis, which means a slowing down in the motility of the gastrointestinal tract. So you'll have things like constipation and IBS-like symptoms. It's a structural, again, not a behavioral issue here. And because of structural laxity, you're going to have gut microbiome disruption because of the dysmotility, SIBO, and a host of other gut-related challenges. So while we as integrative nutritionists may advocate for a whole foods forward and high fiber diets, normally ideal, it can actively be triggering for people with hEDS. So a high FODMAP fiber diet, that's up for compromise, or high histamine containing whole foods we need to be really aware of, as well as large volumes of food, and that because it is challenging to the gut lining and the digestive system. So when in doubt, start low and go slow. That's my advice. We're also thinking if we cannot get our food or get full nutrient absorption from whole foods, we might turn to supplements, right? And that's a wise and logical consideration. However, we also need to take into consideration that many supplements contain fillers, excipients, and artificial additives that could trigger MCAS reactions. I told you, it's maddening. One thing works and the other thing deletes the other thing. So we have to really work on an individual level and look at supplement quality, and also look for things like cellulose, stearates, carrageenans, and artificial colors within your supplements. Also a note, if we're working with elite athletes, that these supplements need to be WADA approved. So we need to look at if they are in line with the World Anti-Doping Agency regulations. So you need to compare quality and whether they are validated by WADA. So compromised gut structure impairs absorption, as I said. So we also need to prioritize bioavailable forms of these supplements. And we will talk about that in a little bit. So let's move on to the next slide. Fatigue and training. This is a big one with hEDS people. So chronic pain, poor sleep, autonomic dysregulation, and nutritional inadequacy are common challenges for people with this condition, and then in turn will lead to fatigue. A common pattern in hEDS athletes is overtraining on good days, followed by crashing and having long recovery on bad days. So nutritional interventions must be woven in a progressive and gradual manner, and be responsive to symptom and not training structure, or training load rather, so that we're not actually being regimented and we cater to the symptom presentation and not the maybe strict training load. So again, slow and low. I would say when it comes to flare tracking, I really encourage this in athletes to log pain, fatigue, GI symptom triggers, and food intake all together, and work collaboratively with your clinician, especially your nutritionist, to find out what might be a triggering factor in your training or your food. Especially when it comes to lack of absorption, we're also compromised in the energy we're absorbing. So we need to be really aware of carbohydrate and protein intake and periodize that along with our flaring up. Also, this population has a higher macronutrient and micronutrient need. So we need to be really strategic here. So if we move on to the next slide. I'm going to look at specific targeted nutritional strategies for each of the trifecta. So starting with POTS. Here, standard sports hydration guidelines are insufficient for POTS. So clinical POTS management requires significantly higher sodium and fluid intake. These are therapeutic interventions and not generalized advice for your general healthy athletic population. As you can see on the side, there's a standard athlete at 1,500 to 2,300 milligrams per day, but a POTS athlete or hEDS athlete is almost double to triple that amount of sodium intake. So electrolyte balance is super important when we're thinking about fluid intake, as well as having enough fluid. But be mindful not to just drink water, but really have added electrolytes, because we want to really account for sweating, we want to account for heat, and you might be a sweater, or you might like a really high sweating load, or you might be somebody who does an endurance sport. So it's really important to be mindful of that if you train maybe in hot climates. Something important to check in athletes struggling with POTS, especially who are menstruating humans, are iron levels. So the most sensitive markers are specifically ferritin, to look at sensitive markers for iron storage rather than circulating iron, because this will also be something to keep in mind between sweating and menstruating and fluid intake. So another practical thing is compression garments. This works synergistically with fluid and sodium uptake, so you have a full clinical picture. So always, I would encourage you before you start giving your clients high amounts of, or if you are an hEDS athlete, start taking high amounts of sodium, please, please, please check with your general practitioner or your medical team. And also if you have a history of certain like heart-related conditions. So this is really important. Do not just go willy-nilly into the night and start taking large amounts of sodium. Let's move on. My favorite, MCAS. I call MCAS the kind of overstimulated toddler of the trifecta. So it's a very, very addictive condition to have. So when we think about food triggers, we are looking at fermented foods. And my heart breaks when I talk about cheese, because that is a big one, especially aged cheeses or canned foods. Alcohol is another big one, spinach, tomatoes, the list is quite long. But many anti-inflammatory nutrient-dense foods are also high in histamines. So this is the catch-22 and the contradictory and maddening information. So you really need to look at that person, how they will individually react to these foods. Because there are some fermented foods that, for example, I'm fine with, like kimchi, but other ones that I'm not able personally to manage. So you want to kind of prioritize fresh over frozen or canned, or rather fresh and frozen over canned. This can be an issue when we think about nutritional strategies for hypertrophy or weight loss, because oftentimes we talk about meal prep. But the problem with meal prep is you're storing food over prolonged periods of time. And as we prolongly store foods, the histamine levels in said food increases every day. So this is something you need to work out as a strategy with your hEDS athlete. We also need to look at exercise load, heat, and cold. Like, again, I'm talking about like your gym or your training environment. We're looking at stress, anxiety. Triggers will oscillate. It keeps you on your toes. So what provokes a reaction this week may not provoke a reaction next week. So do not assume stable triggers. But I would say if you have the luxury to work with an athlete over time, to really collect that data and track over months to really figure out what those potential triggers may or may not be. Also take into consideration synthetic fragrances or heavy cleaning chemicals like bleach, ammonium compounds, or rubber flooring. If you're a CrossFitter or a high rocks athlete, there's a lot of rubber flooring, or even like a power lifter, which can also release gases that will trigger MCAS. If you're a swimmer, chlorine in pools. So maybe it's something to talk about with the venue managers if you are working with professional athletes, if they can mediate the cleaning materials that they use in their studios. That might be something to discuss. You can also think about a low histamine diet that's also being used very successfully in a lot of populations. However, there are short-term identifying triggers, and it can be a little bit problematic to do extreme elimination diets in a population that's already prone to ARFID, which is avoidant restrictive food intake disorder, and also REDS, which I will go into more detail towards the end of this webinar. So if we move on. Now, when we talk about dysautonomia, so your autonomic system, when we think about targeting nutritional strategies, there's not really much we can think about in terms of nutrition, but I will just pertain to exercise load, thinking about how progressive, gradual exposure to either even stress and training, so that we also can't take into account with triggers that oscillate. We want to make sure that this one is going to be a little bit problematic for most people, including myself, who are maybe consider themselves A-type personalities, and most athletes are. I would like to say, get enough rest. Getting enough quality sleep is amazing for your nervous system regulation. But like, think about things like diaphragmatic breathing, maybe somatic relaxation techniques, gentle yoga and Pilates, because I know that there are also variants which are not so gentle. Time in nature, getting off screens, the usual we've heard. But why do I say this? Because rest days will trump any nutritional or training intervention, in my humble opinion. And this is somebody who is training to be a performance nutritionist. So if if you have a training or nutritional intervention, it's going to do diddly squat if your your physiological environment is metaphysically on fire. And rest and recovery is what puts that fire out. So additionally, your training adaptation and gains will be higher during phases of sleep and recovery, which recovery is slower in the hEDS population. So you need longer time to recover and rest. So we also have to think about anabolic adaptations, and growth hormone is highest during sleep and rest. Usain Bolt was known to take naps close to race time. So if it's good for him, it's good for us. Let's move on to the next slide. Micronutrient. So when we talked about collagen, we talked about how kind of pointless it is to supplement, but I do actually also think that it's probably good to break it down to its individual amino acids. So that would be glycine, proline, and hydroxyproline. Both glycine and proline you can get within food, but as hydroxyproline is endogenously produced, so inside you don't actually get it from a food source, it's usually modified when you add vitamin C and iron as cofactors. So cofactors means it helps with the enzymatic reactions that produce hydroxyproline. So yeah, that's something to keep in mind. So maybe increasing bone broth, or if you are maybe a plant-based athlete, increase your legumes for glycine intake. And if you're thinking about proline, again, legumes is going to be one, but it comes to meat, dairy, eggs. But we want to think about like more of those cofactors, which we'll touch on next in the next slide. Oops, my notes. Here we go. So I think it would be very useful to do a full panel of blood values on the following micronutrients, as often hEDS populations will have nutrient deficiencies due to compromised absorption, due to either gut issues or underfueling. Taking a food-first approach, if possible, is ideal, but ideal often isn't accessible to hEDS people. So supplementing, as I said, would be an option. We also want to think about the most researched vitamin in this population is vitamin C. Vitamin C and iron are the most researched evidence-based interventions because they have such a strong correlation with collagen production, but also with ATP production. So that energy molecule that is going to be relative to how much energy availability is accessible to the athletes. So we would want to pair a lot of our foods with vitamin C, rich vitamin C and iron-rich foods, especially if you are a menstruating human. But of course, there are a host of others like folate and iron and magnesium, I mentioned iron, which are also really important in the Krebs cycle that produces ATP. Something to be very mindful of is vitamin B12, because supplementation can lead to side effects, neurological specifically, being paresthesia, which is like the tingling or loss of feeling in your extremities. So be very mindful with vitamin B12 supplementation. Let's move on to the next slide. One thing that's really good, especially if you are a hEDS athlete with gut motility issues or constipation, would be magnesium citrate, because it has a light laxative effect, while biglycinate will help you with your sleep and nervous system downregulation. A really strong antioxidant, which has been shown across different research papers, is, I can never pronounce, is quercetin. It's a powerful antioxidant and has the most evidence to support hEDS, especially as a regulator for mast cell degranulation in MCAS. So let's move on. Dietary approaches. So I think we mentioned before the pros and cons. So if we can identify like through elimination diets, a triggering food, that's awesome. That's great, especially if it's reducing bloating or dysmotility in the short term. However, the con may be that food map diets, like things like onion, garlic, apples, are high in quercetin. So that is also really effective. Again, we want to find what works. It's this canceling of each other out, which we need to work in an integrative manner. So, but also these low FODMAP diets have a risk of over-restriction. And again, we come back to ARFID, prone population, and eating disorders. So we want to be really mindful when we're doing this with our clients or with ourselves. Highly processed foods are often contain additives that are also MCAS triggering, but at the same time, we want to think about, that can be everything from artificial colors to preservatives to emulsifiers. However, if we are reacting to a lot of fiber-rich or histamine foods that are whole foods, maybe we want to still find a way to get our energy. And maybe some people will react to highly processed foods as a quick energy source. We have to be really mindful not to vilify one food over the other because they all have their value and context at different performance stages. So again, work with your patient or your client and try to figure out what works for them for their overall context and health and ecosystem. So food accessibility and equity must also underpin every recommendation. If we can move on to the next one. Recovery. So there is a higher injury frequency and slower tissue repair in this population. So the pain burden is elevated as well as the metabolic cost. So they will experience things like disrupted sleep. So every session of training costs more for the hEDS athlete over the normative athlete to recover from. So when you're working with these population of athletes, set expectations with them and remind them recovery is not laziness. It is structural. Protein distribution across the day to support both muscle protein synthesis and connective tissue repair, like the amino acids that I mentioned earlier, glycine, proline, and hydroxyproline are relevant here. Nutrition should be periodized around symptom load, so not just training load, and integrate the two. Higher energy availability and micronutrient density during manageable periods, and then let's be conservative to easily tolerated foods and strategic rest during flare-ups. So this is where we need, as practitioners or hEDS athletes, to be adaptable, not rigid in our thinking. So graded and progressive load is also where we want to gradually and incrementally introduce new or problematic foods over time and see how they work. Now we are coming to REDS and ARFID. So the risk in this population is really high. REDS is relative energy deficiency in sport, which is actually, even though documented in elite athletes, is becoming more and more common in the recreational athlete, because the recreational athlete is probably also balancing a job and family obligations, as well as having the training load of an elite athlete without the support system of an elite athlete. So their energy requirements are higher because they also have a life load that is requiring energy from them. So oftentimes their energy intake will be way lower than their energy expenditure. So this is something to take into consideration and is a big factor in hEDS population. So symptoms like fatigue, hormonal disruption like loss of mens, or complete lack of periods, stress injury, so bone stress injuries overlap heavily with hEDS. So sometimes it can be missed. So it's very important to maybe even get a DEXA scan done with this population to see if their bone density meets the requirements to avoid osteoporosis in the future. So when we're talking about maybe autistic athletes, they have a highly significant elevated rate of ARFID, so avoidant restrictive food intake disorder. So their interoceptive awareness of their hunger cues and satiety cues are unreliable. And their sensory sensitivities around food are not a preference, they are mechanistic and neurological. So be mindful and considerate and empathetic towards that and work with them and not against them. Elimination in this context can cause serious harm, and always, always work with a specialist if you suspect ARFID eating disorder. Please work within the scope of your practice. It's about them and not you as a practitioner. So no, I think I said that. So no, you're right. Next slide. And I'm so amazed. I made it within time. The last thing I would like you to take away is see the whole person, then build the athlete. Build adaptable frameworks, not rigid plans. This population does not fit a protocol. Be adaptable, be dynamic, and above all, exercise empathy and be humble. Because oftentimes they know more about their expression of their condition than you do. And due to years of self-advocacy and education, they know their body more than you do. I also think that it's super important to work proactively and collaboratively together. Use flare tracking as a shared clinical tool, symptoms, food, fluid intake, training environment, training load, and explore this together. Be curious, not prescriptive. Again, be extremely cautious with elimination diets, and if need, please go see a psychiatrist, refer them to a psychiatrist or a sports dietitian or eating disorder dietitian if you suspect any disordered eating or eating disorders. Please, please, please do not pathologize the person. I know we as nutritionists get very excited at getting into the nitty-gritty of biochemical and physiological frameworks and mechanisms, but we do not want to reduce this population who is already being fractured and decontextualized into more sort of fragmentation in their symptom expression. They are a whole person. They are not broken. They are just navigating a microcosm of challenges in a world that isn't designed for them. But it doesn't mean that they are broken. They are just different. Practice within your scope of expertise. Please build a multifunctional team or a multidisciplinary team. It is so good to work with people who know more than you. So if you can seek out EDS specialized physios, strength and conditioning coaches, psychologists, and if you're dealing with ARFID again, eating disorder, psychiatrists or psychologists. I can even recommend my mentor, Marissa Michael. She's an amazing sports dietitian and climbing specialist. I've worked with her with these populations, and she's an incredibly empathetic and competent practitioner. But if you can't reach her, there's a host of people that I'm sure Simone can also recommend. And with that, we can go to the next slide. I want to thank you. Thank you for hearing my motor mouth go. There's a lot of information, and I thank you for your patience, for staying with me. If you are interested in learning more or getting more resources, I really recommend the Ehlers-Danlos Society and the hEDS study updates that are coming out in December 2026, so this year. Very excited for that. EDS UK, so the ehlersdanlos.org. A really amazing medical practitioner who specializes is Dr. Linda Bluestein and her podcast and website. She has incredible resources and is so informed. So I would really recommend checking into her content as well. But I would also like to say a big thank you to dietitian Nikki Streley, also known as a diarrhea dietitian, who has been an incredible touch point and helped me with so many of the resources and references to base this research of this webinar on. But I also want to thank Simone, who's had to deal with me, because otherwise this webinar would have been 3 hours long. So thank you everyone for sticking with me. And if you have any questions, let me know.
That was amazing, Bea. Well done. I think you did a great job. It is a very complex topic.
It's so complex.
I think you did an amazing job of bringing it all together and highlighting how complex it is and how it's important to work with the individual at the end of the day.
Yeah, an integrative approach is exactly what they need.
Yeah.
Yeah.
So we can open up for just a couple of questions. Feel free to use a chat box, or feel free to unmute yourself as well, because there's not many online at the moment. Just checking the chat. Inga, so disappointed being disconnected. Oh, I'm sorry on your side. I'm sorry about that. But you can always, there will be a recording, so you can always refer back.
And slides will be made available, and you can always email me if you have any questions.
Yeah, so I will send out the slides and the recording to all the registrants. Does anyone have any other questions before we end the webinar? No, I have a question, but it's more of a personal one. You mentioned bone broth. Obviously, bone broth is a good source of all those amino acids that you mentioned.
Yeah.
But it's high in histamine as well.
Yeah.
Is that one? Do you find it yourself personally? Do you react to it or?
Well, I'm vegetarian, so I
Okay.
react to it on a principle level.
Okay. Okay.
But I mean, I do see the value in it, and I'm not somebody who imposes my own nutritional
Yeah.
choices. And again, it's a case of experimenting.
Yeah.
But also, it's worth mentioning that there are different phases in your life with hEDS that can express those symptomology more or less. And it can be, so you can one day like be fine with bone broth, but oftentimes it's a traumatic event that can exacerbate the symptomology. So it can be the death of a loved one. It can be going through menopause or puberty. It can be maybe a traumatic event like a sexual assault, unfortunately, or it can be high levels or even viruses. So it's worth tracking, even if this person has tolerated something like bone broth before, and unfortunately has gone through one of these moments in their life, if maybe what they've tolerated before changes. So worth keeping in mind.
Yeah. That's why, yeah, that reminds me of the timeline that we use, right, in integrative practice, how important it's to do the timeline and do that repeatedly, I think is important as well.
Yeah. So.
Right, if there's no other questions, oh, Melanie, feel free to unmute. You raised your hand. I like how you're using all the emojis. That's fun.
Yes, I use this a lot.
Yes.
I was wondering beyond because yes, for sure, when I've heard of this, I think of hypermobility. But what would you say is like the second most common symptom of this that isn't hypermobility? And how do people kind of like find their way to a diagnosis? Because it feels like it's so like there's so many layers and like you said, comorbidities to have this. So yeah, did you find any research that showed what's the most common in those things?
Most common is chronic pain. So if they have been experiencing chronic pain that is diffuse, changeable in locations, long after a trauma or an injury has happened, so 3 months plus. And this is a big one that is also an indication for hEDS. Another one, I just lost my trail of thought. What was it? So it's doesn't matter. But yeah, chronic pain is one. Oh, recurrent injury. So if you have recurrent injuries, like whether it's like tendinopathies or muscle tears, or even like maybe stress fractures, if this is recurrent and your recovery is slow, this could also be an indication. And this is the thing, it's about seeking out EDS specialized physiotherapists. Usually they will be somebody to then refer you on to pain specialists, because it's usually, my diagnosis at least, came from a pain science specialist and not from a generalized practitioner. But again, it had to do with a lot of self-advocacy. It is tiring. It is tiring.
Yeah, I can only imagine. Thank you for sharing. It's very informative. I learned so much.
I'm glad.
Yeah, a lot. Thanks.
You're very welcome.
I have a question. Why does Nikki Streely call herself the diarrhea dietitian?
Well, her specific, I mean, I also wondered that. I mean, it's certainly memorable, let's say
Yes.
that for sure. She has celiac disease, and she spent a lifetime having a lot of diarrhea and talking a lot about diarrhea. So I think she's lent into it.
Yes. Yeah, I just wanted to share, obviously, so we'll share the slides. You've got all the references here that B has based her presentation on. And yeah, well done, B. This was part of her level 7 diploma studies. So all the students have to do the research, prepare the slides, and deliver an actual webinar. And I think she's done an amazing job. So well done, B.
Thank you.
And yeah, thank you to everyone for attending tonight. Some of our social links, websites, YouTube channel, and so on, if you want to engage with us. If you have any further questions as well, if anything comes up, and especially if you're watching the recording, feel free to email us, and I can always forward your question to B. And with that, I'll end it for tonight. So thank you, everyone, and I hope you have a good evening.
Thank you for attending.
Bye, everyone.
Bye.
Bye.